Larry and Gaston be talking about living back pain free or attempting to do so. We've been tasked with giving you guys some evidence-based medicine and evidence-based practices on how to do this. Just quick show of hands, anyone ever had any sort of back pain at all? Ever? Yeah, right. So I don't need to help trying to convince you this is an important topic, but we'll show you why it's important anyway. We have no disclosures. Let's go Buckeyes. First big test this weekend. So, most people usually start off with a joke, cartoon, whatever. Memes are pretty popular now. I could do back pain memes all day. You get back pain, you get back pain. There is simply no solution to get rid of back pain. If someone could get rid of my back pain, that'd be great, right? And really nobody has time for any of this. So, why do we care? Looking at the numbers, 2/3 of people will experience back pain at some point in their lifetime. I think that's an understatement. I think everyone raised their hand. Most people usually experience it in the late 20s to start. Annually, almost a quarter, almost 25% of people will experience the back pain for at least one day in a quarter. And just all comers for primary care offices, back pain was listed as a diagnosis in a visit or some sort of billing purpose, which is pretty alarming. And it's the 7th most common reason to actually seek medical care. Some estimates down to 10th most, but generally it's in the top 10. And it's pretty much 2% of all office ambulatory visits. Again, just continue with some numbers. Like I said, it's second really only to URIs for what people experience. So people get common cold and then they get back pain. Like that's it. It's a huge cost. It's estimated around $90 billion of healthcare money. $30 billion in addition from days off work or other things that come as sequela from that. 1/3 of all workers' compensation cases are related to back pain. Athletes get it too. So 70% of all elite athletes, be it at the collegiate or otherwise level, have had an episode of back pain. The good part of that, this is both for athletes and the general public, 90% of them resolve within 6 to 12 weeks. If there's one thing you take from this, remember that, because that's big. 40 to 50% of cases resolve within a week, and about 3/4, even if they have true nerve root involvement, will get better in about 6 months' time. So just a quick bit on history mechanism, right? So things we look for, mechanism of injury is always important. Motor vehicle accidents, trauma, falls, those are obviously important. Whether or not you have other things going on, right? If you have some bladder bowel issues, fever, chills, if you're not able to sleep with this, numbness, tingling going down the leg, all really important to kind of differentiate how severe your back pain is. Also, like I said, prior injuries, prior surgeries, those kinds of things. Other medicines, things that we know make back pain worse. So elevated BMI or obesity that we know in this country is a problem, leads to back pain. Tobacco use, huge prevalence with tobacco use and back pain together. Lifting, and we'll get more into that. Prolonged sitting will really hit those. Job dissatisfaction has actually been shown to correlate with back pain. Then, of course, family history, social history, and it's a big reason for litigation, getting back to kind of the workers' compensation component. We're going to do it at the end. Do you have something? Yeah. This one. I'm sorry? Correct. Those are separate data points. So 90% of all cases will get better within about 6 to 12 weeks. Okay? Including in that 90%, half of those are actually going to get better within a week. And then completely separately, looking at only those that have nerve root involvement, so radicular symptoms, 3/4 of them actually get better in 6 months. So the percentages don't have anything to do with each other. They're standalone issue. Yeah. So I was going to bore you with anatomy, but not really. Okay. So most common causes in the primary care setting, 85% lead coming from muscle strains, non-specific musculoskeletal origin. Basically, someone goes in and they don't really get an answer, right? That's 85% of the time. Fractures only down to 4%, tumor 0.7%, autoimmune, rheumatoid arthritis, all of that's kind of grouped into one, only equals 0.3%, and infection 0.01%. Again, showing the majority of these back pains will get better. The severe cases are rare. Things, again, kind of reiterating the red flag symptoms, if and when these are present, then we do have a little more cause for concern for infection, tumor, trauma, or more severe symptoms that we need to be a little more proactive with. So is there any good news? Again, back pain research in general, there's a lot of it, right? Depending on the resource you choose or the journal article you find or the time period, it's going to vary. You're going to see anything between 2 and 100%, and you're going to see everything in between there. But generally, very few people develop chronic back pain that actually experience it. So one of the things you can do is be proactive, right? This poor gentleman on the carpet trying to do something. He's not sure what he's doing, but he's going to do something. One of the other people I want to mention kind of developing the chronic issue, Donnie Thompson. I'm not sure if anyone has ever heard of Donnie Thompson, but he's a professional weightlifter, now turned physical therapist. He works in South Carolina. What's really cool about him is he had, and a lot of professional lifters have this, unfortunately suffered 3 herniated discs. And within 3 months' time of the MRI showing 3 herniated discs, physician telling him, hey, you might not be able to squat again, he put up the numbers listed there. So 3 months of time, he went home, he performed physical therapy, he did home exercises, he took some anti-inflammatories, he got rid of all that stuff, kept working, and he squatted over 1,200, benched over 900, and deadlifted over 750 pounds. He's the only person to do over 3,000 pounds from that series. So kind of a good story to hang your hat on when you don't feel like going to work. So more imaging, but no problems, right? So there's been a number of randomized control trials that show basically if you compare routine care, so you come in and we give you an idea of what to do, versus come in, x-rays, MRIs, a ton of imaging, the outcomes are the same. Outcomes being things that matter, right? Your pain is the same. Your function is the same. Your quality of life, and as well, being a mindfulness session here, mental health, all comers the same. And the other issue with that is that there's a weak correlation between imaging and the actual issue, right? So MRI, great technology, we're able to find a whole bunch of things, but I can't tell you how many patients I've seen with an MRI nerve root sticking out on the right, but all their symptoms are on the left. So not necessarily is it always going to be concordant. So just because we have something to point at and blame doesn't actually mean that it's causing the person's pain. This was a cool little tweet that the British Journal of Medicine released a few months ago. I absolutely love it. To kind of reiterate that point, they took all of the research articles that were out there showing abnormalities in people that have never had injury, never had any issues. And you can see, and I won't read through all of these, I'll stick with the lumbar region there, that 37% of 20-year-olds who have never experienced pain, so we're getting towards half of those people, show disc degeneration on their either X-ray or MRI. And when you get to 80, of course, we would imagine 96%. But again, these are asymptomatic people. These are people that don't have pain. They don't have loss of function. And you can see the disc bulge, partial rotator cuff tears, partial labral tears, everything else around. So again, just reiterating the point that just because you take a picture of it in this day and age, I mean, I know Instagram's big and all that, but just because you take a picture of it doesn't mean it actually correlates to your pain. And again, the American College of Physicians put out a best practice advice, kind of reiterating the harms of X-ray imaging. What is it, right? So you're now labeled, right? So it's in your chart. You get back pain. If you're looking for life insurance in general, that's there. The radiation exposure, both from X-rays and CT scans. Some people have other comorbidities, right? Issues with their kidneys, issues with allergies, unable to have contrast dye and other things. And again, just the price. This was done by the Occupational Environmental Medicine. They, again, looked at MRI, and this is just to kind of put some more numbers on it. So as you guys can see, the percentage of disc bulge in asymptomatic, again, these guys don't have pain, nothing. They're good to go. Over half of the 20 to 40-year-olds have a disc bulge or herniation, down to 21%, but still we're looking at like a fifth to a third, depending on the age, of how many people have a herniated disc on MRI without any symptoms. So the United States Task Force put out these. It's a busy slide, I know, but don't worry about it because we're going to go through all of it. But basically, they say you can try some Tylenol. It's not good. Nsaids are better. You should go with that. Lumbar supports don't help, and you can consider some other things. And then everything else I've already said, imaging doesn't really help you. So looking specifically at a few other tests, Nsaids. This is not accurate. Well, we'll go through it. So Nsaids have been shown to be slightly more effective than placebo. Again, this is a small magnitude trial looking at 13 randomized controlled trials. Low evidence of this, but basically it said that placebo and ibuprofen, naproxen, depending on which they used, nobody really got better, and there was no difference between ibuprofen or naproxen. So NSAIDs were not helpful. Yeah, sorry. I don't know why this is up like this. We'll just skip to this. So can we prevent this? Known risk factors, like I mentioned earlier, you have heavy physical work, frequent bending, lifting, twisting, squatting, kneeling, awkward lifting, prolonged static postures, high television viewing time, getting over 2 hours a day, prolonged standing, again, as we mentioned, the psychosocial demands, and the psychological factors. Looking at the odds ratio, so pointing out a few of these specifically, prolonged standing, you're going to get almost a 1.48, like 3 to 2 essentially, rate of back pain. Same thing with awkward lifting, squatting, kneeling. Those are things that we can adjust. Same thing with television time. Pretty easy to actually determine or limit your viewing time. Whereas some of the psychological and psychosocial demands aren't as easy to change. Can't really change your work demand, right? Does that all make sense? So can we actually prevent it? Hopefully, yeah. So by limiting squatting, kneeling, and the awkward lifting, etc. And that's when I'll turn it over to Gaston.
Good afternoon, everybody. My name is Gaston. If you guys do have any questions, physical therapy related, just try to save them for the end, and I'll be happy to answer them. So going right in here. As a physical therapist, a lot of times when I see people coming in for low back pain, generally the cause and mechanisms of the injury are based on spinal flexion. What I mean by that is just the bending forward motion. A lot of us, all of us, have eyes in the front of our heads, so all the things that we do are in front of us. We don't generally operate with things behind us. We'll turn, we'll bend, and that's usually where most of the problems, like I said, become. So what I want to do next here is kind of show you and demonstrate the correct ways of lifting and bending, especially for our healthcare professionals out there and the people who spend a lot of time, whether it's sitting, prolonged sitting, or sometimes even the standing position can alter some or give you some back pain. So if you guys could just humor me here, I did bring a umbrella pull from my patio set so I could demonstrate properly. Not to get in front of the slide. So what I'm trying to display here in this picture is just neutral spine mechanics. So we know, as what the research suggests, that neutral spine mechanics are going to be a little bit better than having flex spine mechanics when bending. So if you can see what I'm doing here, I got 3 points in contact. One of them is my kind of belt area. Another one would be my thoracic spine, which is above this space that I have a gap for. And the other one is my head. So things that you could do, like brushing your teeth, or those people who have back pain when they're doing the dishes. Generally speaking, it's because they lose that gap. You kind of get this teeter-totter effect. What research suggests, and what I see most of the time, what helps people is just that small clinical pearl of education, keeping those points in contact with the low back, or with the belt loop rather, the thoracic spine or mid back, and then the head. If you're doing dishes, you can obviously bend the head. The importance here is being placed on the low back. Again, this position is something you want to try to avoid, especially as you get into doing a little bit more lifting things like we do in healthcare. Just could we wait till the end if that's okay? Unless you need me to talk louder, I can do that. One of the committees that I was on formerly before I got into the sports medicine was safe patient handling in a hospital, and what I saw a lot of was, every month we get numbers of employees getting injured on the job, and most of the time, generally speaking, it was nursing staff. You're lifting dependent patients, you're doing so kind of in awkward positions like I showed you where you're bent down. So some of this could definitely be applied for some of them. It's all preventable. You try to do everything you can for the patient, but you also have to make sure that you're taking care of yourself too. So I want to get into a little bit of these positions when you're doing more of those endeavorless lifts where you're picking something up, especially with weight. So when we talk about the squat lift, that's just that. If you got the bar on your back, you're taught not to do this position here. You want to push the butt back, push the chest out to do that lift. You can do all of that stuff. still maintaining that good spinal neutral position. There is the golfer's lift for those people who are, picking up a piece of paper. It's not necessarily something that gives a ton of people issues, picking up light things like that, but you're still maintaining a proper level of spinal neutral position, which is definitely beneficial for us as far as therapists, because a lot of times just this cueing is pretty helpful. It doesn't eliminate people's back pain, but it's just like I said, this is important for a clinical pearl here. So what can we do? What I tend to do a lot with people, because most of their injuries occur basically through a flexion moment, is we kind of reverse the trend a little bit. We spend so much time in our day bent forward that getting into some lumbar extension is actually beneficial. So in the picture that we've got here, just some important cues that I like to tell people while they're in front of me and I'm working with them is we got to maintain no kind of contraction from the lower half down. So with the back here being in that prone position when you're on your stomach, you don't want to engage necessarily your glutes or even your paraspinal muscles. So this is essentially becoming, at the end of this position, a lift exclusively with the arms to try to allow that spinal extension to take place. We do in therapy a lot of core strength, and that term is used loosely, and it's kind of, it covers everything. We're not walking around with six packs and everything like that when we say, you got to build your core, but the most important thing is when you do start to do those heavier lifts with patients, or you go to pick up something you didn't know it was going to be as heavy, we want your core to be engaged. But in this position here, we'd rather it not, because we want to get that extension moment occurring in the lumbar spine, which tends to help the majority of patients. And as far as therapy and going a little bit deeper here, there are things that we offer aside from just a few prone press-ups and things like that, but hopefully none of you have to experience that, and you can kind of balance out your moments in flexion with a few prone press-ups, maybe to start your day and to finish your day, so that you can kind of, like I said, balance yourself. One other thing we see a lot of is the hamstring length. It's so highly correlated with back pain. The research shows that people who have generally tighter hamstrings, as a result, it kind of pulls their pelvis back, and that motion right there just induces a lot of spinal flexion already. So if you've ever had a little kid sit on your lap, you'll know what I'm talking about, the bony butt kind of phenomenon. That's where your hamstring's attached to. So, pulling back like this will induce some of that spinal flexion that we want to avoid. So your static hamstring stretches are going to benefit you, because it allows you to get into this position a little bit better so that you don't have to hunker down. And with that, I'll turn it back over to Dr. Nolan here. Thank you.
So essentially, everything that we talked about, I feel like this really sums it up for you guys. Basically, prevention is the absolute key. It's going to happen. See it as a part of aging. Back pain will occur, but if we can do something to prevent it from getting worse, then that's really the take home. At this point, more than happy to answer any and all questions. I think you have one. She's good now.
Did I answer your question earlier? Yeah? Okay, excellent.
Yeah. If you guys will humor me for like 2 minutes, let me pull up some better slides, if that makes sense. But yeah. The story is still going to be the same. Overall, the treatments are limited, right? So basically the evidence is mixed on every single treatment. But the fact is it works for people, right? So anyone that's ever been on prednisone knows that so I already mentioned the Nsaids. Basically, Nsaids are useless. But anyone that takes ibuprofen when they have pain, anyone that takes naproxen when they have pain, you know that you feel better. And that's kind of the issue, is that we, from a logistical standpoint, when we see evidence, we see that it's equivocal or not better than placebo. So every NSAID comes with it also some sort of risk, right? A lot of people have chronic kidney disease or hypertension, high blood pressure, other types of issues that limit your amount of use of the anti-inflammatories. So we take it with a grain of salt, but then again, everything's going to be better within 6 months. So we're not looking at long-term solutions here, right? We're looking at short-term solutions. Tylenol, maybe slight improvement, but at 1 week, 2 weeks, 4 weeks, and 12 weeks, it was basically the same as placebo. So giving people sugar pills versus giving them nothing, or giving them Tylenol. And again, compared to NSAIDs, though, much, much less side effects. Generally, more people can tolerate Tylenol, with the exception of some liver issues. Really, most people, this is where they start. But you guys, if I polled, I'm sure half of you in the room would say Tylenol does nothing for my pain. Systemic glucocorticoids, so oral prednisone, as well as injections, both, again, short-term relief. We're talking like days to weeks at most. And then also, again, a high-level amount of adverse events, including elevated glucose for our diabetics and infection risk, et cetera, from the actual procedure. And a meta-analysis of 18 trials basically said steroids don't work. Muscle relaxers, very, very effective. They've basically been shown that a number needed to harm, however, was 12. So take that, again, with a grain of salt, because sedation is the biggest harm, which I personally prescribe it with that purpose, because you're coming with back pain and you're unable to sleep. So take this at night to help you sleep. Because of that, that's where their effectiveness is in the short term. But as far as, again, fixing any of the issues, the underlying soft tissue, you're going to go back to the prone push-up. You're going to go back to the biomechanics long term. Looking at Neurontin and pregabalin, so Lyrica and gabapentin, same thing, a little bit of improvement, maybe against placebo. The problem with this and all other studies, kind of highlighted in that third line, that Lyrica and anti-inflammatory were better than the anti-inflammatory alone, but I just told you that the anti-inflammatory alone isn't better than placebo. So again, all of the controls versus the treatment groups in these studies is really limited. It's really difficult to get a true double-blinded trial, and when they do, they see this, showing no effectiveness. Looking at a few other things, in non-conventional medicine or just other modalities, massage kind of helped to some extent. People, again, short-term relief, felt good for a few days, maybe a week. But if that's a few days in a week out of not taking an anti-inflammatory that can cause GI upset or other issues, I think that's a win. Interestingly enough, depending on the trial, anywhere between 2 and 25% of people that receive massage actually had increased pain. Yoga, there was a non-blinded, kind of hard to blind a yoga trial, but basically they looked at yoga versus people that were put onto an exercise program, and then other people were just told to go do whatever you want. Yoga was statistically better, but clinically everyone was the same. So their pain got better, statistically more so than the other groups, but the other groups also improved pretty dramatically. So we'll say from a pain rate of 8, where they all started, yoga got to a 4, the other group got to a 6, and the other group got to a 6. So everybody got better. So is yoga really better? Not really. And kind of at the same line as that, the Pilates, there's 126 trials, which actually surprised me that there was that many trials looking at Pilates alone. No change in outcome. Some said that there was some improvement in your pain and some improvement in disability. But again, this is minimal intervention. And the problem with all three of these, unless you were here, I believe at Ohio State, you guys could get free massages up to like 5 years ago or something. Like insurance actually covered, which is crazy. Yeah, not since I've been here, so sorry about that, guys. But because of that, the cost of massage, the cost of yoga, the cost of Pilates, right? Like these aren't cheap. Even if you try to get it on your TV, you're looking at like a monthly bill, or if you're going to a studio, you're looking at costs. So is the cost there going to improve your back pain more so than doing a few prone push-ups to start your day or a sun A in your bedroom? Probably not. At least the evidence doesn't show it yet. Finally, looking at like manual manipulation or osteopathic manipulation. Anecdotally, I do this a lot. I see people get better. Again, the evidence isn't there. Why is the evidence not there? Again, running into the hard to blind whether or not you crack someone's back. They're going to know. I'm going to know whether or not I'm doing it. So that makes it an inherent flaw or two. And it also comes down to the technique chosen. Also comes down to the user, like the operator. Like how good is that person? If someone has never done it before versus someone that's been doing it for 20 years, I'd probably take the 20-year vet. Looking at some of the other ones, again, these are getting into the cost stuff, but looking at acupuncture or the electroacupuncture, home-based cupping, mobilization, manipulation, clinical massage, all were proven to be effective, but only statistically, not real clinical significance. Counter strain, which is a very popular technique because it's so well tolerated, the relaxation massage, and then you've seen all the heat, cold, hydrotherapy, ultrasound, all that stuff, also proven not to be effective. And that's kind of where. Yeah, everything he said. No, honestly, it's difficult because I tell you not to do imaging, I tell you not to give you medicine, but I do that, right? If someone comes to my office, I end up getting imaging most of the time, right? Because there's that you want to know what's going on. No matter how many times I show you the evidence that 80 or 90% of people are going to be okay, you're not worried about 80 or 90%. You're worried about one person, not even a percent. You're worried about you, and you want to know, which is reasonable. And same thing, I've taken medicine. I know how much relief I get if I take a Tylenol. And everyone here has had a medicine that's given them relief, and they've had medicine that hasn't given them relief. The problem is the evidence just isn't there. And I don't know that it's going to ever be there soon because of the inherent flaws that I've already told you about with the inability to blind and inability to do that. So basically, again, the good news is you can prevent this. If it happens, it's okay. It will get better. And there's things that you can do, and there's a ton of them, even though maybe not all of them work for everybody, right? This is not a cookie cutter thing. No one treatment modality is going to work for everyone in here. What you need to find is the thing that works for you. Yeah.
And one of your first slides, you said that in a certain period of time, most of these go away in like 6 months, 6 to 12 months. Is
Yeah.
that various interventions?
With any intervention or no intervention, yeah. The vast majority. What's that?
Any or no?
Any or no, yes. Again, if you spend enough time looking at the data on back pain, you can find something that you like and that you want to read, right? Because there's just that much data, and every time it's equivocal, right? It's okay, it's kind of there, it's kind of not. But looking at all comers in general, even if you do nothing, you're going to get better, which is kind of, so why do anything? Yeah, go ahead. I'll let you follow up, and then I'll hit you back.
Do you have any opinion on surgery, like microdiscectomy and things like that?
Yeah, of course. Purposely left it off the slides, but I'll say this, I'll go out on a limb here. Back pain is not fixed by back surgery. The only time that we're talking about discectomies or back surgeries, and they are wonderful, we're talking about only when you have true radicular symptoms, you're having other issues beyond pain itself. We're talking about things going down the leg, numbness, tingling, weakness, trouble with urination, trouble with bowel movements, these kinds of more severe issues. Pain itself, I rarely recommend surgery, again, because the evidence isn't there.
That went with my question. After 6 to 12 months, you still have someone who has pain. I was going to say, is surgery an option?
Yeah, it's certainly an option, and it would depend. Again, it's not cookie cutter, but because there's so many modalities, I'll run through all of them, right? So majority of the time, I have a referral bias, right? As a specialist doing sports medicine, most people have already tried a few things by the time they get to my office, so I'll try whatever they haven't. And again, it's just trial and error, trial and error, trial and error. Because unfortunately, if they've had pain for 6 months, it also means it's not an emergency, right? Because it's long going, it's chronic. So we want to kind of figure it out as quickly as we can, and we want to get them better, but that doesn't mean I'm jumping to the operating room either. Oh, sorry.
I was just wondering about sleeping positions.
Mhm.
In the morning, in my case, I have a lot of pain that I cannot even sit, so I have to actually stretch, but in the opposite direction.
Do you sleep on your back?
I
Or
sleep
on your
my,
stomach?
Back side, the other side. I
So-
try everything.
Okay.
Pillow, no pillow.
It'd be difficult to say without actually laying hands or more importantly probably watching you sleep, getting an idea, okay, you may lay down on your back, but how much time are you actually spending on your back versus your stomach? So in general though, the strengthening, like he said, we use core strengthening pretty loosely, but you may need to turn on certain muscles particular to you, and that may help you with that. And that's kind of what you're doing inherently, right? You're taking care of yourself by doing that stretch in the morning, obviously. So maybe more anterior core might be better. Yeah, go ahead.
Can you speak to backpack safety? Because we got a lot of people that are wearing backpacks and have back pain, so I'm just curious to know what your recommendations are around backpacks.
Yeah, that's a good question. I've never had that question before, so I'm kind of ad-libbing here. heavier loads obviously are going to create extra weight to you. The thing about backpacks, though, is it kind of brings you backwards, right? Like you don't necessarily, I mean, through the weight that you have on your back, you bend forward a little bit. I've always been told, I'll go from what I've been at least brought to, is that if you tighten your straps up a little bit more as opposed to putting that load directly onto your low back, it is a little bit more beneficial to have any like statistical evidence or to you know, I would say that that's probably my best recommendation. You know, I know that kids are, and I remember it too, carrying like 7 textbooks in your backpack and it's like 25 pounds. You know, I would recommend a backpack versus a duffel bag in that situation, just in the sense that you're obviously going to induce some side bending, which can, you know, be a little bit more demanding on your core to try to maintain. So,
I have a question from online.
oh, okay.
Is there any evidence for adopting an anti-inflammatory diet and resolution for back pain?
No evidence, but again, if it works for you, go for it. So especially in light of everyone looking for turmeric, glucosamine, various other gluten-sensitive diets, even though having a true gluten-free or allergy. In general, if you cut out all inflammatory foods, I promise you, you're going to feel better, right? In general, everyone's going to get that. So is there evidence behind it? No. For the same reasons, can't blind. People are going to see what they're eating, all that stuff. And the stuff realistically isn't going to be paid for research, to be honest. But so no evidence, but yeah, I absolutely encourage people to try those things first, again, because the other modalities also don't show any evidence.
Great. The second question is, does treatment change for frequency of SI joint involvement for a low back pain?
Say that again. Frequency.
Frequency of SI joint involvement for low back pain. Does treatment change?
No. So I would define low back pain as anywhere between the lower ribs to the inferior gluteal fold. So I include the sacrum and SI in that. So same thing is true. Some of the studies, I kind of grouped them together because, I mean, we could do a couple hours or a couple days on this alone. But most of the studies either looked at spinal pain or lower spinal pain versus lumbar pain versus SI. But again, the consistent data came out the same.
Thank you. Question right here.
Do you encourage for soft bed or hard bed is good for back pain?
You guys are going to hate hearing this. Whichever one works for you. Problem is, it's a lot easier to try different anti-inflammatories at the pharmacy because they're all, $4 to $12-ish, right? So not too expensive. I'm not advocating everyone go home and buy 6 different beds that are all hundreds of thousands of dollars each. Definitely, if you're in the market for a new bed, please, when you're at the store, lay down on it, like use it, like explore it a little bit. You test your car before you drive it, right? The bed, you spend a third of your life on it, so I definitely recommend trying different things, especially with pillows. Pillows are relatively cheaper, and you might find that you get some significant relief from whatever you've been doing to kind of going the polar opposite of that. Yeah.
Are there any studies on Biofreeze or anything like that?
They kind of group them all into like topical analgesics for the most part, and so you're looking at your Biofreeze, your Tiger Balm, that whole arnica gel, all of that. Again, the reason I like those a lot, even though the evidence against placebo is equivocal, right? It's not much better than placebo. They're relatively cheap for the most part. Biofreeze being, I mean, some of the brands are expensive, but no side effects. That's the take home for those. There's nothing bad. There's no kidney issues. There's no liver issues, right? If you're taking 4 grams of Tylenol over time, that's going to affect you. Whereas there's no negatives to it. So a great place to start.
So for the back pain caused by the muscle strain and the slide disc, will the exercise be same?
Yes. You're going to hate this answer too. Basically, anything that you feel, and this kind of goes back to the book bag as well, if you're not getting pain from it, if it's not making you worse, it's pretty much okay to do. And I say all this, and I'll give you guys a quick story. I saw a patient recently whom had a really benign exam, no real injury, a few weeks worth of pain, looked great, talked about things, no need to do anything for the same reasons I just said, right? No imaging, no medicine, you're going to be fine. Try this. Here's some home exercises. Progressed 3 days later, had a full herniated disc, couldn't do the exercises, couldn't get out of bed, et cetera. So like, you'll know, like it kind of presents itself, if that makes sense. But yeah, as long as you feel good to do it, you're fine to do it.
Thanks for coming out and talking to us about this.
I can't hear you, I'm sorry.
Do you have any recommendations for people? Oh, now can you hear me? Okay. Thank you for coming out and talking to us. Do you have any recommendations for people who have back pain from the cause of bone spurs or the stenosis, actual physical problems that are making the nerves?
Like a spinal stenosis. So I guess the question is if you have one of these other things that I kind of brushed off on that the majority of people don't. So if you are one of the unfortunate people that have a spinal stenosis or a radicular issue and it's been going on for a while, what can you do? Start with the same stuff, honestly, because spinal stenosis, for instance, you're not going to reverse it. The treatment for spinal stenosis is strong, again, loose term here, core work, strong physical therapy basically throughout life, and prevent any potential surgery at the end, which because of the translation, a fusion is probably there, but a fusion at 78 is a little bit better than a fusion at 43.
Just to add to that a little bit, so spinal stenosis, just given its nature, tends to respond, at least from a physical therapy standpoint, better to flexion-based exercises. So what I mean by that is in the position, if you're lying down on your back, bringing your knees to your chest is the position you're flexing your spine. And we're not talking loading the spine and bending down like this. So there are some nuances and some subtle differences depending on the diagnosis term that you have. Just to give you a heads up. Generally speaking, the research that I've read indicates that it's just, and clinically I can say too, that someone who's got stenosis, which is that narrowing of the spinal canal there, it's hard when you narrow the space between those segments and things of that nature. Going into extension actually bumps into those segments a little bit harder going through extension. So flexion is going to be a little bit more of a preferred position for patients with spinal stenosis, given my experience.
Any other questions? All right, if you don't mind, give them a round of applause. Thank you so much. Thank you all for coming.